just had a patient that had come in for persistent puffy nipple. He was treated with for puffy nipple in the past, but now he has this more of a poofiness that's going on with his areola. So just going over the management of this as a secondary, where you're having persistent puffy nipple, there's really 3 or 4 things that I'm looking at. One is, is there any retained breast tissue that would need to be removed? And sometimes it's not breast tissue. Sometimes the breast tissue is removed well, and what happens is scar tissue will form underneath that like a little marble. So going in and, this is the same person, I've just drawn the procedure on the side. Going in and actually removing whether it's breast tissue or whether it's scar tissue. And then what I will do is remove this crescent type excision, and that will involve often a little bit of the areola, because what I'm going to be able to do with that is to actually reduce the size of the areola, and even more importantly, to be able to pull the areola down, much like I always equate it to pulling on a bed sheet to get the wrinkles out. So really we're pulling on the areola to get the wrinkles out and also to get rid of some of that tenting. Another important thing that I've done, and I just learned that it's important, is we need that areola to contract, because it ends up being too poofy, and in order to get it to contract, what I will do is just roughen up the undersurface. So literally turning the areola 180 degrees and then roughing up the undersurface to get that tissue to contract down. So that's how I treat persistent puffy nipple. Well, thanks for listening. We do at least 10 of these procedures a week. So if there's something that we can answer, some question or some problem or something that hasn't been addressed, we see a large volume of gynecomastia. So if you have a particular question, please let us know and we'll try and get back to you.